most of you use this protein, this immunohistochemistry for confirming the diagnosis of mental state. Of course, there are now also exceptions. I don't go into much detail. Now, how important is it? Is it just nice for pathologists to make a new diagnosis? We also decided now we could make this diagnosis reliable to see what patients with this disease, how this was. It was a small cell lymphoma, but it's a low-grade disease, you don't have to treat it. But when we collected data of the patients with this disease, we realized that it was not a low-grade disease, that it was aggressive, and that it needed treatment. It was not very common, but also not uncommon. And so we were now able to define the disease based on pathology, and the clinic was very typical. Also at that time, in 1996, we already found that there was a prognostic marker in these patients, and this is still being used nowadays. Nowadays we use fish for maybe this diagnosis. You may use fish for this diagnosis. So techniques evolve. But I think the most important point is that we now know that the Ki-67 stain is a prognostic marker, that there is a good guideline how to use it. And what's very important is that we now have treatment for this patient. So as I showed you, the survival was not so good. The median survival was 31 months at that time. Nowadays the survival is much better, it's twice as long. And this came when the European consortium started to collect these patients and start treating them with specific therapies. So I think this is a very nice example of how for pathology we define a disease, see how patients with this disease behave, and try to understand the disease and start treating it. And I think the outcome for patients with mantle cell lymphoma, as we call it nowadays, is much better than it used to be. I think this is basically what pathology is about. And this took a long time. Nowadays, I think we can probably be a bit faster. Pathology is about 130 years old. This is from a museum. I don't know that pathologist lab still looks like, and I'm pretty sure that at the time that it was really used, it wasn't so shiny and clean as it looks here. But this is how a pathology laboratory looked at that time. Nowadays, pathology is different. Pathology laboratories are not in the cells anymore. We are closely connected, hopefully, to our patients. We get the biopsies. We need to process them fast. We have good taxation. We have standardized taxation. We have computers that we can use for documenting. We use cytology combined with histology. We still look at slides. Slides is still what we do, but we don't stain them by hand anymore. Of course, using faster processing, we can make diagnosis of histology within a day. You see still a lot of hands. It's still one of the areas in medicine where hands of personnel are critical and crucial. But basically looking at this, looking through a microscope at the same slide, is the thing we do already for 130 years, whether we look at cells or tissues, both we can use. We need to interact, of course, with radiology. It's very crucial. We need to go a bit further. We cannot do only immunohistochemistry, we need also to do DNA testing as a predictive marker, like the HER2 amplification in breast cancer. So we go back to our dark rooms looking at fluorescent slides, or maybe do it in another situation. We make frozen sections to make diagnosis in a short time. We participate in multidisciplinary meetings, talk with molecular biologists. This is what pathology looks nowadays, so very different from how pathology looked, I think, 130 years ago. The pathology changes. It has changed over time. Some of you have seen the coming of histochemistry, very few. It's an old trade, but we see still good improvement of that. Electron microscopy, we still use it, not a lot. Enzyme histochemistry, we do it for muscle biopsies, for instance. Immunohistochemistry, we do really a lot, all of it. DNA analysis coming on. There's been expression profiling, and nowadays it's next generation sequencing that we are talking about. And it's interesting, if you go back to the old papers and the newer papers, all there have been comments from clinicians, but also from pathologists who say, well, with this new technique, you don't need the classic pathologist anymore, you don't need the HNA anymore, you don't need the microscope anymore. But as we all know, we all need them. And I'm pretty sure that we will need them in the future as well, because I'm very convinced that also next generation sequencing, also expression profiling, is only valuable for patients if it's used in the context of what we as pathologists do, knowing the disease, understanding the disease and making diagnosis. But this was my prediction, and as you know, prediction is difficult, especially when it deals with the future, so I may be wrong. So this is what I see as a progress. We make progress all the time, we make better diagnosis. But another area I think is very important, we do need specialization. I believe that the general pathologist is important in training. I think pathologists need to be trained broadly, but I'm pretty convinced that we need for many diagnoses specialists. And this is just an example. This is a stain for MSH6, one of the mismatch repair genes. I'm not sure if you can see very well in the back of it. You see here tumor cells, and you see here tumor cells. The nuclei of these tumor cells and the nuclei of these tumor cells. So, just a question to you. Do you think that this is a positive cell? Is this tumor positive for this antibody? Yes. Who thinks it's positive? Please raise your hand. No. And why not? So, you can say. Compared to this. This is normal. Yeah. And here, is this positive? Yeah, the stain is equally small. They are both from the same run, same quality assurance program. Well, I think indeed it's very important to realize that you have to prepare this moment. This is what happens a lot when you use nuclear staining and you use cyclate buffer in your pre-treatment. You have this small background staining. So you always have to look for this stain. You have to understand what's happening. All the tumor cells need to be strong compared to the surrounding stroma. Now this is an example of what I see a mistake being done. A lot of people really the details of mismatch repair effects and the importance of that for hereditary colorectal cancer. Another example. This is a CD20 stain. This is a Reed-Sternberg cell. Maybe not so good to see from other cells. Is this positive? This is the lower magnification. This is what happens if you do quality assurance, and if the quality assurance people say that the stain has to be very, very strong, which is not correct. You can see here the normal B cells. If you pump up the CD20 stain, your Reed-Sternberg cells become positive, and your Brookside states it's negative. This is way too strong staining. But persons who like strong stainings, especially with Ventana machines, I don't know if you have them, they like this, and this happens, and then you can think that this is a positive cell, but it's negative, it's too strongly stained. So I think it's important that this type of understanding is there, and you have to understand, of course, that CD20 is present in the Reed-Sternberg cell, but at very low level, it's a B cell. It's a very low level staining. But if you pump up your staining, you will not. Another form of progress, what we see, not only in classical pathology, what is a lymph node metastasis? This is a lymph node metastasis. You see here tumor in the lymph node. This is in TNM staging 4, 5, and 6, and this is not only for colorectal, this is for all tumor types. This has always been a positive lymph node, but this not. In TMM4, this was not a positive lymph node. This is an area of tumor outside of the primary tumor in the fatty tissue. But in TNM5, which was 6 years ago, it was decided that if a tumor tissue is not collected to the primary tumor, we call it a lymph node metastasis. So this same lesion became N1. This was not a very good idea, many people thought. And it was not based on any clinical studies. So in TNM6 it was decided again that it's not lymph node metastasis. But now it was decided that it's probably tumor extension and it's T3. And the same here. This is a 2 millimeter large, smooth surfaced tumor surrounding the primary tumor. This was not considered a lymph node metastasis in TNM4, also not in TNM5, it was called T3, but now in TNM6 it was called a lymph node. Again, not based on any clinical data, just a decision by a membership committee who appointed themselves that they are the experts on TNM staging. And this is what we all should do. We made a survey in the Netherlands who is really using the criteria that are prescribed by the TNM. Actually, a lot of pathologists just do it themselves. They think, well, it looks like a lymph node metastasis, I call it a lymph node metastasis. So this is not in progress for pathology. And what happens, of course, is if you go over time, the same patient, here there's no problem, we all agree. But here the same patient goes from stage 1 to 3. And this patient was stage 1, stage 3, and now stage 2. The same patient. And a totally different outcome. Colorectal cancer, for instance, if you stage 1, you have a 95% survival. And if you stage 3, you have a 40% survival. You get adjuvant therapy. We do not so well here, I think. This is something I really am irritated about, how this is going. And one of my co-workers is now in the committee, is Iris Nachtegaal, and she made these slides, and she's now trying to convince all the others that if you change the TNM, you have to have data to do that. So that's the progress, some good progress, some not so progress, differentiation. But transformation is what you're experiencing now, I think. This is the type of slides we see all the time now on pathology meetings. Of course, this cartoon has nothing to do with reality, but it helps us to understand what's going on. All these proteins that are here, they are floating in the cytoplasm and moving about and are breaking. But these schemes help us a lot. Now, one of the big changes we are seeing now is that we are using in the clinic therapies that are based on molecular changes in tumors, targeted therapy or personal medicine. All these tools are in vogue. An example here, and I think this is the example that really changed the pathology a few years ago, is the EGFR route. The EGFR route is an important route. You know that already for many, many years. It's infected in different tumors. If EGFR is bound by the ligand, you get atomization and downstream pathways start. Treatment of patients with EGFR blocking, and it started with colorectal cancer, was working, but not in all patients, actually in a minority of patients. So the industry thought, well, this expensive drug, if we are going to use it, we need to select the right patients. So molecular biologists started to think about what's going on here. And of course in colorectal cancer, the RAS oncogene is well known. And it's downstream from EGFR. Located here. It's the most important pathway in colorectal cancer. Now, if you block this pathway here, you hope to block everything downstream. So also the RAS activation pathway. However, if you have a mutation in RAS, what happens is that the normal situation where active RAS becomes inactive and active again, circulating, doesn't happen anymore. RAS remains